Hey Rebellion followers, Salim Rezai here. So I want to talk about the PALACE trial, which is basically direct oral penicillin challenge in patients with low-risk penicillin allergy. Now, this was published in JAMA Internal Medicine, which is maybe a journal a lot of us don't follow, but I thought this trial was totally worth mentioning because I can see this helping us out in the emergency department. Now, I've listed the PMID number at the bottom, so you can go to PubMed and pull the paper yourself. But essentially, the clinical question these authors were trying to answer was, is direct oral penicillin challenge in adults with low risk penicillin allergy safe and effective compared to standard of care skin testing followed by an oral penicillin challenge? And what they did was a non-inferiority randomized clinical trial performed at 6 sites, 3 of which were in North America, 3 of which were in Australia. The arms of the trial were direct oral challenge, where they just gave a challenge dose of a penicillin or penicillin equivalent, compared to standard of care, where they did a skin test followed by an oral challenge. Now, in terms of what did they use, it depended on the site. The lowest available therapeutic dose at each site is what was used. Now, the most commonly used test dose was amoxicillin 250 milligrams, and the second most common was amoxicillin 500 milligrams. They also did use PenVK as well as a medication that I've never actually prescribed called flucloxacillin. Now, for the skin testing, they used ampicillin 25 milligrams per ml, or they used PenG at 10,000 units per ml. And if the patient had a negative 2-step skin test, they then got a direct oral challenge with a penicillin equivalent. The way they determined if somebody was low risk was this thing called a PenFast Score, which I've never actually seen or used, but it's pretty intuitive and pretty straightforward. So the pen portion of the score was a penicillin allergy reported by the patient. If the answer was yes, then you proceeded with the assessment, which was this FAST score. So the F stood for if it had been less than 5 years since their last reaction, they got 2 points. If they had anaphylaxis or angioedema or severe cutaneous adverse reaction, they got 2 points. Not for each, you could have either or and. And then for treatment, treatment required for the reaction, they got 1 point. Then what they did is they added the total, which was anywhere from 0 to 5. And 0 being the lowest risk, meant that you had a less than 1% chance of having a reaction. A 1 to 2 meant you had a low risk of positive penicillin allergy test, which gave you about a 5%. A 3 was a moderate risk, which gave you about a 20% chance of having a reaction. And then a 4 to 5 was a high risk, which gave you about a 50%. Now, this is a validated score. This isn't something these authors just made up. It's been reviewed both prospectively and retrospectively, and now they're incorporating it into their practice. The primary outcome is not one that most of us would care about in emergency medicine, but it was physician-verified positive immune-mediated oral penicillin challenge with 1 hour post-intervention. So within an hour of getting the oral challenge, did they have a positive immune-mediated reaction? So there were 377 adults randomized. Of the patients that they screened, 69%, almost 3/4, were eligible. And of the ones that were eligible, 86% of them were actually enrolled in the study. Now, this is something we can all relate to. 61%, or almost 2/3 of the patients, the reason they had penicillin listed as an allergy was because of some childhood reaction that they don't recall that their parents told them. Now, 92% of patients got the intervention per protocol the way it was meant to be, which means the majority of patients got randomized correctly to either just an oral challenge or a skin test followed by an oral challenge. Now, the primary outcome that we discussed, the direct oral challenge was 0.5%, the standard of care was 0.5%, meaning there was only 1 reaction in both groups. And the 2 patients who had a positive challenge was a mild cutaneous skin reaction, both of which resolved with a 1-time dose of an antihistamine. Now, there's a few other outcomes of note that I think are worth mentioning here. So first of all, if we look at the direct oral challenge, in terms of the 5-day adverse events, the median time that patients were having a reaction, if they were going to have one, was about 4 hours. For the standard of care, it was about 6 hours. Now, when they looked at total adverse events, so this includes immune mediated and non immune mediated. So, non immune mediated would be things like nausea, vomiting, diarrhea, headache, things that are not an allergic reaction. We can see there was 22 patients, or 11% of the people that they tested in the direct oral challenge. And there was only 20 patients, which was also 11%, in the standard of care challenge. Now, the 5-day confirmed immune-mediated event was obviously less than that. It was 9 patients, or 5%, in the direct oral challenge, and it was 10 patients, also 5%, in the standard of care challenge. So no one had anaphylaxis or angioedema in this study, and nobody required hospitalization or an ED visit. I think are very important things to kind of mention here. Now, this is the key. The penicillin allergy label was removed from the patient's chart, and 99.5% of the people that got challenged with a direct oral challenge, and 97.9% who got standard of care. So here's a couple of commentaries from me about this study. The majority of patients, almost 95% of them, had a PenFast score of 0 or 1. And that limits generalizability to patients with a score of 2. There just wasn't enough people with a score of 2 to comfortably say that this actually works in an ED setting. The second commentary is that this was an open label study, so both patients and physicians knew which treatments were being provided. But the physicians who were determining both immune and non-immune mediated adverse reactions were blinded to group assignments. It was one infectious disease doctor and one allergist who had no idea what patients were randomized to, and so the fact that this was an open label study should not impact the number of adverse reactions that we're seeing. So here's the clinical bottom line for this study. In adult patients with a history of penicillin allergy so the author's conclusion is a PenFast score of less than 3. I added an or here, which is a PenFast score of less than or equal to 1, which is my conclusion because majority of these patients had a score of 1 or 0. They did not have a lot of patients with a score of 2. So my conclusion is a little bit more conservative than the author's, but a direct oral challenge allows a scalable, safe, fast, and cheap way to delabel patients of unverified penicillin allergy. And this will have huge clinical impacts in terms of antibiotics that are available to our patients, reducing potential drug resistance, and maybe even saving hospitalizations because only IV options are available. So there you have it. I will have a full blog post out on this on Rebel EM as soon as I can. It has to go through our peer review process before I publish it, but I just wanted to get my thoughts out on this study. So let me know your thoughts, comments, and questions. Thank you for tuning in. And as always, until next time.